Hi, good afternoon, and welcome to TEPHI Infection Prevention 102 Preparedness Module. Before we begin the Infection Prevention 102 Preparedness Module, we'll briefly like to introduce who and what TEPHI is. First, my name is Kayla Rush, and I'm one of today's presenters. I graduated from South Dakota State University with my bachelor's in biological sciences, graduated from UT School of Public Health in 2008 with my master's in public health with concentrations in environmental and occupational health. And after that, I began my career in the field of infection prevention in acute care hospitals here in Texas, where I obtained my certifications in public health, healthcare accreditation professional, and became certified infection prevention and control. During the COVID-19 pandemic, I had the opportunity to work in acute care hospitals here in Texas, a long-term care and skilled nursing home facility in New York City, and acute care hospitals in California before returning to UT Health to pursue my PhD in epidemiology with infection prevention and control. The Texas Epidemic Public Health Institution, or known as TEPHI, is headquartered at UT Health School of Public Health here in Houston. It is funded by the governor's office. It is a state organization that works to keep Texans safe and the Texas economy strong by preparing for the next infectious disease outbreak. TEPHI continues to work on developing critical programs, producing educational summit based on public health preparedness and certification programs, and currently expanding its programs, training, and more, while growing partnerships and offering resources across the state. Under TEPHI, there are three operational cores. One, the Training and Resource Core. Two, the Readiness Core. And three, the Communication Core. The Small Rural Health Systems program is under the Readiness Core, and its overarching goals of our programs are to provide small rural hospitals with infection prevention, education, and readiness, and provide rural communities that were highly impacted by the pandemic with local resources that they can use to prevent and mitigate disease to avoid small rural hospitals reaching capacity. Let's begin the Infection Prevention 102 Preparedness module. We'll hold all questions to the end and leave some time for some questions and answers. This module's learning objectives are to explain the elements of an infection prevention and control risk assessment, identify effective resource management practices, describe basic waste management best practices, and recall lessons learned by UTMB SPECTRE Director Dr. Susan McLellan. The first section we are going to discuss today is how to conduct an infection prevention risk assessment. What is a risk assessment? A risk assessment is a systematic process that involves identifying, analyzing, and controlling hazards and risks in our environment. Why is this needed? It is to identify hazards and determine what measures are or should be put in place to eliminate or control the risk in the workplace. When should you conduct a risk assessment at your facility? A risk assessment is conducted when a new process is added or additional steps in the workflow are introduced, when changes are made to existing processes or workflows, when a new piece of equipment or tools are introduced into the workflow, or when hazards or problems occur. Why is this important? It is important because risk assessments help identify hazards that pose risk to the health and safety of employees and patients so that proper controls can be implemented to reduce harm. The main focus of why one conducts a risk assessment is to create a safe environment for everyone in their area. When conducting a risk assessment, you'll go through the following steps. One, identify the hazard, as in what is the hazard, potential hazard, or issue that's currently occurring. Step two, determine who is involved in the process and how they could potentially be harmed. Is this staff, patients, or visitors? Walk through the steps of the process from start to beginning so we understand the process completely and the risks involved. Step 3, evaluate the risk and decide what precautions need to be taken or put into place to prevent harm from occurring. What is the level of risk of the event from occurring and the risk of potential harm due to this event? After deciding what precautions are needed, you'll move on to step 4, which is implementing the controls and precautions. Step 5 is recording your findings and communicating them. This can be done in the form of an email, a written protocol or policy, or another type of intervention. Communication is key and should be done with all those who could be harmed. This includes patients, staff, and visitors. This could be also done in the form of a unit meeting, an individual meeting, as in talking to patients at the bedside, notification blasts, or another way. As we say in healthcare, if it's not documented, it did not occur. Lastly, we'll do step 6, which is review the assessment and update it as needed. When you reassess, make sure you communicate your findings to all the individuals involved, such as department leaders, staff, and patients. During your review, if there's any changes or updates that you have made during this review, it must be communicated to those involved so that we all know what current version we are in to help prevent harm to staff and patients. As we saw with the risk assessment steps, it's important to implement controls. But before we can implement them, we need to understand the hierarchy of controls. Implementing the hierarchy of controls will help us reduce risk to our patients and staff in our environment. The first step the first step in the hierarchy of control is to eliminate the hazard by physically removing it. Next, an individual can substitute the hazard by replacing it. Third, an individual can implement engineering controls such as isolating it from people that the hazard is occurring, and following engineering controls, a facility can implement administration controls, which come in the form of creating a policy, procedure, or protocol to reduce the risk of harm to staff and patients. Lastly, individuals can wear protected personal equipment to help protect them from the hazard. This is useful to implement when conducting your risk assessment and determining what controls are needed to be put in place to reduce the risk to patients and staff. Different levels of the hierarchy of control will be implemented based on the level of risk, which can be determined by looking at the risk matrix. As we mentioned in conducting a risk assessment, it is vital to consider the likelihood of event from happening, the consequences, and the level of harm, which is known as the risk matrix. Here is a visual tool called the risk matrix that is commonly used to help understand the relationship between the likelihood of events occurring and the impact of the consequences. The likelihood of the event occurring is categorized into almost certain that the event will occur, likely the event will occur, possibly the event will occur, unlikely the event will occur, and it's a rare event that will occur. The consequences are categorized into insignificant, minor, moderate, major, and catastrophic. The measure of risk will be categorized as low, medium, high, seen on the chart, as in green being low, medium being yellow, and high being red. The goal is to be in the green zone where the event is rare with low risk that produces an insignificant level of harm, compared to the red zone where the event is most likely certain to occur with catastrophic consequences resulting in high risk. By understanding the hierarchy of control, an individual can change an event from a high risk situation with lots of harm to a medium risk with moderate consequences with the possibility of the event occurring to pushing it to a low risk event that is unlike or very rarely going to occur that produces insignificant um, consequences. There are two types of risk assessments. There is your situational risk assessment and the infection control annual risk assessment. We will talk about both in detail. The first one we're going to discuss is the situational risk assessment, which is usually conducted when an event occurs. It is essential to use the who, what, where, when model when understanding the event, assigning a level of risk using the risk matrix, as we just discussed, and then implementing the hierarchy of controls. The components of the situational risk assessments are as follow. You want to look at who is at risk? Is this a patient, a staff, a piece of equipment, a workflow process, an overall facility operation process, or a unit process? What? What processes are involved? This could be an individual process, such as a specific issue with a certain patient or staff member, or a systemic process of who is affected in the facility and affects the overall operation of the facility, or could this be a special circumstance that it's to this individual with this specific procedure, such as maybe supplies is back ordered, maybe a piece of device isn't working well, and so it needs to be substituted. Therefore, a specific procedure can't be performed on that patient. Next, we want to look at where this is occurring. Where is the situation occurring? What type of unit or department is the situation happening in? Is this in a medical unit, or is this in the ICU versus the OR or surgical unit? Or is this in a certain department such as sterile processing or central supplies? The location is key, and different measures will be taken based on the location. Lastly, when? What time of day is this issue occurring, and at what time point during the facility's operation is occurring? Is this event happening at 7 a.m. during shift change in the morning or 7 p.m. at shift change in the evening? A different approach may be implemented due to the staff level and the patient activity level based on what time of day the event is occurring. Next, we are going to discuss the Infection Control Annual Risk Assessment. The Infection Control Annual Risk Assessment is a grid that is used as a visual tool to develop an infection control program priorities and stratify infection risks based on geography, location in the community, and the patient population. It will be conducted annually and is one of the main components of the infection prevention plan for that year. This risk assessment is ongoing and is in a continuous process. If an outbreak does occur, it will take precedent over the infection prevention plan. However, the IC plan will be used to help navigate and address the outbreak. The annual risk assessment will include the follow columns, as you see here: program components, probability of performance failures, impact, infection prevention systems, score, and the annual facility goal. You will assign a level of risk to each of the columns and set an annual goal. You will score each potential as high, medium, low, or never. You can set your facility goal on any number, however, usually 5 or 7 is typically used as a reference goal. Depending on your specific facility's need, you may add additional columns to your annual infection control risk assessment. The scoring process is as follows. If you score a component as 0, it indicates that the process is going well. There's no issues. Low or 1, processes are initiated and being followed. Medium or 2, processes are in place and going well, and the outcomes are improving and being sustained, i.e., you've had issues in the past, but they are resolving. And high or 3 scoring measure indicates that training and education sessions may be needed to be scheduled, which indicates issues are currently occurring. The roll total will be summed to give you an overall score for that component. This score then is compared to the goal number set for that specific component. If the number is at or below the goal, it is indicating that the goal is met. If the number is higher than the goal, it means that the goal is not met. The overall goal is to have a lower number from the scoring metric, and the lower number indicates that processes are going well and you're having less issues in your facility, compared to a larger number and a higher score indicating that there are more issues and more opportunities for improvement. Here are just some examples of potential risks and problems that you can use in your facility's risk assessment under each subcomponent. These are just some examples. Your facility may include some of these or many of them, based on what service lines and patient population your facility serves. The following slides will just provide some examples of an annual risk assessment for a specific facility as an example. Here is a complete example of the facility annual risk assessment. You can see the different components and scores for each category. The scoring is based on the previous year's events, i.e. issues that happened last fiscal years, such as breakdowns in processes and procedures, or if new processes, procedures, or service lines have been created, you want to include them so that you can monitor and assess them. You will use the previous year's infection prevention plan to help score the issues and set goals for the upcoming year. Another resource that you can use to help score issues or include them under program components is information you receive from your local county or state public health department and or material sent from CDC and WHO. Here's another example of an annual infection risk assessment. There's similarities in the next section we will talk about is implementing effective resource management practices. Just one second. It seems like we're having audio issues.
You're back.
Can you all hear me now? Oh, all right.
Yes.
Sorry for that. Let me just back up a second. This next section, we're going to talk about implementing effective resource management practices. The number one thing that will help you implement effective resource management is planning. First, you would like to determine what resources are required and estimate how much you will need. If budget allows, add 10 to 30% of extra product to help create a small surplus. Next, you will acquire these resources. You must identify how these resources will be obtained, transported to you, and where you will store them. In this stage, think and plan if there are any storage requirements for these resources. This can include certain regulations, such as how many inches from the ceiling things must be stored and off the floor, along with temperature and humidity regulations and recommendations. Considering whether individuals transport, store, and use this resource will need specific training. If the answer is yes, they do require specific training, plan to have the training conducted before obtaining the resources. Following that, you will want to manage these resources. You must identify how these resources will be used and how much of them you will use. This is a specific process called burn usage. Lastly, you would like to control the resources. This could be involved placing them in a specific type of location, such as an open versus secure access location, or having a central or multiple sites locations to store them, so it makes it easier to access. We will discuss each component in detail. Determining resources. When you're determining your resources, here's some good questions to ask yourself, your department, collaborating departments, and leadership. Getting buy-in from others is critical when identifying resources and understanding the process. You will need to think through what and who's involved in the process by obtaining the resource to storing it to using it, removing, and disposing of it. If the resource is a specific type of equipment, ask the following questions. What equipment is exactly needed? Is there specialized training required to use this piece of equipment? And is there a specialized location needed to store this piece of equipment? Also think about, is there a specific vendor I need to use to obtain this? And how will maintenance be performed on this type of equipment? Some of these questions can be answered by obtaining the instructions for use or IFU manual. If the resource is staffing, ask the following questions. What staffing skill set or ratio is needed? Is there specific training, experience, certifications, credentials required of these staff members? Or can training be done before use, or is it done while learning to complete the task? Acquiring resources. When acquiring resources, you must go through the approval process. This looks very different at each facility. This involves out specifically looking at what budget is this coming out of? Is this item coming out of a department budget or is it a facility budget? The approval process of and the leadership hierarchy is very different. So if you have questions, look specifically at your facility. Sometimes the approval process starts with the department and then goes through the facility leadership or all the way up to the executive board. This can also be dependent on the item's amount and the cost. For clarification on your facility's specific process, contact your department lead or facility leadership for clarity. A good question is to always ask is this within the budget? Another critical thing to think about when acquiring resources is finding a specific vendor. Different challenges come with working with a local versus out-of-state vendor or a national or international vendor. While shopping around for products, contact the vendor or manufacturer for the instructions for use or IFU manual. Obtaining this before and reviewing it will help answer some questions so you know exactly what you're buying and what is needing to maintain a piece of equipment. It will also help you understand very fundamental components of equipment, such as cleaning, storing, and operating the device before purchasing it. Another thing to be mindful of when acquiring resources is the process of transporting these resources to your facility. Does it require specialized transportation requirements such as temperature control or pressure requirements? Does this piece of equipment require disinfection, high-level disinfection, or sterilization? This is something to discuss with the vendor before ordering it. Also, think about what type of waste this equipment creates. If it generates waste, waste management practices must be considered and understood before purchasing it. In the next section of the module, we'll briefly discuss best waste management practices. Managing resources. You'll need to identify how these resources will be obtained, transported, and managed. You will need to look You will need to think about where to store them and develop an inventory system to monitor them. In this stage, think and plan if there are any storage requirement for these resources. This involves thinking about storing regulations such as how many inches from the ceiling. In the United States, it's always 18 inches from the ceiling and off the floor, which is always 8 to 10 inches off the floor, along with certain temperature and humidity regulations and recommendations for certain supplies and equipment. When developing your inventory system, use the first in, first out method, which is known as FIFO. This will help you keep track of products' expiration dates and ensure you are using the product before it expires. Next, you will want to calculate your burn usage, which is the term meaning how much of the item, product, PPE you are using or burning through. You will then create an ordering schedule based on your burn usage, which involves ordering weekly, monthly, quarterly, semi-annual, annually, or special occasion. If budget allows, always tries to build in an extra 10 to 30% of product to create a safety net and a small surplus for you to have on hand. Lastly, you will want to control the resources to ensure effective resource management. This could involve placing items in a secure location, which only allows specific individuals to access them, versus allowing open access where any individual can access them. Due to the location and the facility's operation, having a centralized location or designated multiple locations can be both beneficial. When selecting an area, also consider engineering controls that are needed for storing, such as temperature and humidity and pressure, as we've discussed. Based on these control, it will determine if a centralized or multiple location areas are feasible. Another critical factor is who is using the item. Is this item used for only specific individuals where having a secure one centralized area to access it would be beneficial? Or is this where multiple individuals and multiple units will be accessed, therefore having multiple locations as storing would be beneficial? Determine if you're having a centralized versus multi site access will highly affect your operations. So try to think about that in advance. Lastly, you want to track and trend your product usage. This project should be monitored and audited to determine if there's any way to improve the storage, usage, and operations of this item or equipment. Constantly evaluate the process and makes improvements as necessary. Finally, when implementing effective resource management practices, it is essential to have a backup plan. Look at alternatives for products and vendors in case the product gets backordered. Also, think about product substitution. This can be beneficial in case of a situation where there are multiple product shortages, as we saw during the COVID-19 pandemic. When planning on using products, consider seasonality events that affects uses, such as going into certain weather events, as in a hurricane event, or if there's an infectious event such as seasonality of influenza, to be considering of how that will affect your burn usage. Lastly, think of a backup plan to store these items in case the primary storage location requires specific engineering controls that fail, i.e., temperature, humidity, and pressure is being out of compliance. The next section we will talk about is provide a brief understanding of waste management. Waste control is an integral part of the biologic public health response. Proper handling, storage, transportation, and disposal are critical for mitigating risk. Improper waste control can have potentially significant and severe adverse health effects and can be detrimental to public health, the safety of staff and patients, and the environment. Medical waste, often called infectious or hazardous waste, is waste contaminated with blood, bodily fluids, or other infectious agents. Medical waste can be broken down into three categories: infectious medical waste, radioactive waste, and sharps waste. Infectious waste is commonly seen in PPE, IV tubings, body tissues, and specific disease-causing pathogens. Radioactive medical waste is frequently seen with specific isotopic material, and sharps waste is usually seen with needles, scalpels, and syringes. Each type of waste, infectious, radioactive, highly hazardous, and non-infectious waste, needs to be stored in a different color-coded waste container. As a visual tool to help staff dispose of properly. Red containers indicate infectious substances. This can include waste that has come into contact with body fluids such as PPE, IV tubing, and body tissue. Yellow containers should be used for radioactive waste. For using for gowns and gloves used during radiotherapy or chemotherapy should be disposed in these yellow radioactive substance hazardous containers. Black containers are used for highly hazardous chemicals like chemotherapy treatment and hazardous pharmaceutical waste. They are commonly located in areas where specific drugs are given and usually found in pharmacies. Lastly, the blue containers are used for non-hazardous waste. An infectious substance is known as is known or is reasonably expected to contain a pathogen, which is an agent that can cause disease to humans and animals. Infectious substances have an accompanying United Nations identification number, which is known as a UN number. This lecture will focus on two types of infectious substances, category A and category B. These categories are established by the U.S. Center of Disease and Control and Prevention, the United Nations, and the World Health Organization, along with working along experts in the fields of medicine, microbiology, health and safety, and transportation. In the United States, the transport of these substances is regulated by the U.S. Department of Transportation, known as the DOT. Category A infectious substance characteristics are that they are easily disseminated or easily spread from person to person. They are highly lethal and cause serious public health effects. It will cause significant public health panic and disruption. Category B infectious substances characteristics include being moderately easy to be disseminated, causing moderate morbidity, and are less lethal than Category A agents. They require fewer special public health preparations compared to Category A. Here's a list of the current Category A and Category B substances in the United States. You can see as Category A, some very common ones are anthrax, botulism, the plague, smallpox, and for Category B, we have Brucella, Salmonella, E. coli 0157, and others. Infectious substances, as we were previously talking about, are body tissues that should be disposed in leak and puncture proof containers and stored in well ventilated areas to minimize the risk of exposure to airborne pathogens. Containers in these areas where infectious substances are stored should be clearly marked as highly contagious to alert others of the potential hazard. You never want to flush these substances down the drain or dispose of them in regular trash bins, as this can pose a risk to staff members, the environment, and public health. Steam sterilization and/or incineration is the recommended method for treating and disposing of infectious substances. For more details, refer to your specific facility's infectious substance disposal protocol and procedure to see what method that your facility uses. Medical sharps waste pose a risk to human health and the environment if not handled and disposed of properly. It is essential for all to follow specific guidelines to ensure that these substances are safely handled and disposed. To properly dispose of sharps, you want to place them in a leak and puncture proof sharp container immediately after use. You never want to recap needles or syringes. This puncture proof, leak proof container should be left closed and only filled to the designated line to avoid accidental sharps injuries. The suggested treatment method for disposal is autoclaving and incineration. As before, you can refer to your facility specific protocol on disposal for more details. Here's just an example of a poster that facilities can hang in these areas to help their staffs identify what items should go into what type of waste. And we have a link to this poster at the end of our slide deck. And lastly, radioactive waste should be stored in a secure area with minimal access by people to reduce the risk of exposure to others. The storage area should be well marked and secure to prevent unauthorized access. Do not dispose of radioactive waste in the regular trash. You will need to label the container with the international symbol for radiation alert, as you see here, the UN number 2911. To alert others of the potential hazard. It should be in a yellow receptacle bin, as you've seen here on the slide. To reduce the risk of exposure, you want to keep the waste on site until radiation levels drop to a safe level for handling. During this time, the waste should be stored in a secure area and monitored regularly to ensure safe handling and disposal. Next, we're going to hear from Dr. Susan McLellan on lessons learned in the field. Dr. McLellan is the professor of infectious diseases at the UTMB, the medical director of the biocontainment unit, and the director of the biosafety and research related infectious pathogens, and the director for the special pathogens excellence in clinical treatment, readiness, and education SPECTRE program. She's had a lot of training in internal medicine, pediatrics, and infectious disease, where after her training, she returned to Tulane, where she held joint appointments both at their School of Medicine and School at Public Health before being recruited to UTMB in 2018. She has over 25 years of experience in the field, and we're happy to welcome her to hear some of her stories in the program that she leads. So let's welcome Dr. Susan McLellan.
Everybody, first I want to really thank you folks at TEPHI for inviting me to present. And so what I'm going to start with is a little bit of why am I presenting to you, right? Okay, so I'm an infectious disease doc. That is really what I am, as opposed to, and one who's been involved in a lot of public health programs and stuff in various places. But what I am now is this special pathogens excellence in clinical treatment readiness and education. And that is the program, as you'll see, that we have developed to support preparedness for being able to take care of people with the scariest pathogens. So remember those select agents that we just discussed? That's the kind of thing. So obviously, infection control gets pretty important in that realm. So why do we have, why do we have RESPECs and so on, which I'll explain to you what they are. So everybody remember, or if you didn't remember, maybe you read about it, Ebola in West Africa, first recognized in 2014, although it had started in 2013. And that slope that you see going up there is the number of cases. And well, what's that got to do with the fact that we have a biocontainment unit? So you heard I'm the medical director for the biocontainment unit at UTMB, and I'm about to explain what that is real quick. So what it has to do with biocontainment units in the United States is that a number of people were transported back to the United States to get care. And most hospitals were not ready to provide care, not because of any particular medical understanding or anything like that, but because of the IPC issues. So what's a SPECTRE and a NETEC and a RESPECT, which is sort of what the basis of what we are. So in 2014, after these people were transported back, it was recognized that the United States needed increased capacity to take care of patients with highly transmissible pathogens. And so this was part of the emergency Ebola funding that was appropriated. And a bunch of it was for ASPR, which was then the Assistant Secretary. Now it is the Administration for Strategic Preparedness and Response, for the renovation and alteration of privately owned facilities to improve preparedness and response capabilities, basically to develop a capacity to bring in somebody who might have a highly infectious pathogen and provide safe care and effective care. Oh, that's a slide that didn't come through. Oh, okay. Ignore that because this is what it is. The first thing that didn't show was the fact that originally this was called the National Ebola Training and Education Center, which is why it's in ETEC. But this is part of what was funded through that money, a collaboration of three of the institutions that originally took care of Ebola patients. So Emory, New York, and Nebraska. And they provide guidance and education and training for institutions that are developing the capacity to take care of somebody with a special pathogen. And 10 RESPECs were funded at the same time. The ones that are a little bit green there are the three new ones that were just funded last year. So we now have 13, and you can see that one of those is at UTMB in Galveston. So there's at least one for each of the human health and services regions. So UTMB built the BCU, the biocontainment unit itself, biocontainment care unit itself, over 2015 to 2018. And then as sort of the world changed and COVID happened and so on, ASPA really developed a plan for a larger framework called the National Special Pathogens System of Care in order to assure that throughout the country there would be readiness to actually take care of individuals affected by special pathogens. So SPECTRE was created to support that and the expanded goals, which is more than being just sitting there waiting for an Ebola patient to show up, but also to do things like I'm doing today, network out, help to reach out across the state and across the region to make sure that other people are prepared for this to happen. So I'm assuming most of our audience here is Texas. Okay, so the Texas plan for a special pathogen, everyone should know for a patient who has potentially Ebola, is that any hospital should be prepared to take care of them long enough to get them diagnosed before they send them to us. All right, so let's talk about what that means. So when we talk about stories from the field, the reason that I'm involved in this is because I went off to Ebola land in 2014 because it happened in some places where I had friends. And so this is the kind of place that I was working in. This is the kind of place I'm working in now, which is a little more relevant to most of y'all. So let's, and that's what our unit looks like, by the way. It actually looks like typical hospital rooms to a great extent, but there's some engineering built into there, and I'll mention that a little bit again. All right. So what's important here, though, for most of the audience is, okay, well, I'm not in a biocontainment care unit. I'm associated with a small rural hospital, perhaps. So let's talk about what do you want to think about, what you can do where you are, because one of these patients can show up anywhere or be there with a concern. So let's start with an easy one. Let's start with a physician who was working, not doing Ebola work, but was in a country with an Ebola outbreak. CBC is the Centers for Disease Control and Prevention has started the airport monitoring program. As you may be aware, during, for example, the Ebola outbreak, all travelers from the affected countries were sent to 5 specific airports and registered with the CDC. CDC then lets their state know that they are returning from an Ebola affected area and they should be monitored. So she goes back to work because monitor doesn't necessarily mean that you have to stay home or anything. But then she develops simple symptoms, basically a temperature, no other symptoms. She otherwise feels well. And she calls and talks to the state TEPHI. And actually, she's going to talk to her local health authority here in Texas and says, well, I'm getting ready to drive myself over there. I've already talked to the infectious disease specialist. Okay, there you are at that hospital. What are you thinking about? Now, I wish I could do this in a more interactive fashion. I think we've got too big an audience for that. But one of the first things that the team and the infection control people and the care people are going to want to know is how sick is she? And they're going to ask things like, is she a wet patient or a dry patient? So what does that mean? Why do you care? Why does it matter that she seems to have called right away when she got sick? What does it matter that she wants to drive herself to the hospital? What are the things you need to think about that? So here's your little picture, and you may have seen it before if you've looked at anything having to do with Ebola, that talks about the fact that most people start with a non-specific febrile illness. They might have a stomach ache, might have a headache, might have things like that, but they don't start their illness by bleeding out of their eyeballs. They actually don't finish it that way either. But many of them do, over the next couple of days of their illness, develop a lot of gastrointestinal signs and symptoms, which can include vomiting and diarrhea. And the longer they're sick, the more virus there is, and that means those fluids coming out have more virus. So let's go a little bit over here. Wet and dry, no vomiting, no diarrhea, et cetera, and so on. Wet, vomiting, diarrhea, common with Ebola. If we're talking about a respiratory illness, so for example, MERS or Nipah virus, then if they are coughing a lot, if they're having a lot of upper respiratory involvement and runny nose and producing sputum and phlegm, that would be the respiratory sort of version of a wet patient. Okay. And same as I said, usually dry is early in disease, less virus, less infectious because they're not producing as much infectious material. But if they're a wet patient, they're probably sicker. They probably had it longer. They probably have a higher viral load. Healthcare workers need more protection, and you also need to be able to provide care more rapidly. So those are the kind of things that I, as a healthcare provider, want to make sure that somebody is thinking about so that I can do my job, which is to provide care for that patient without worrying about my own safety. Now, timing, much of the same thing in terms of your safety and your infection and so on. If it's early, they're hopefully not as sick. You've got time to think things out. An IP provider would have time to talk to the medical team, make sure they have what they need to be safe, and so on. And we'll talk a little bit more what that means too. And then proximity. Okay, what are you going to do about the fact that she says she's going to drive her own car? What if she gets in a car wreck and she might have Ebola and she bleeds on somebody? Are you comfortable doing that? Or are you going to call your EMS? And if you call your EMS, are they going to say, oh yeah, we're cool with picking up somebody who might have Ebola? Have you, thought about that? And what are they going to do to protect themselves during transport? And are they going to expect the receiving hospital to decontaminate their transport? Okay, let's talk about a little bit more problematic potential patients. So let's say a missionary couple, not necessarily as well educated, lots of community contact, coming back from the same place. So again, they come through an airport, they get caught by CDC, they get reported to the state monitoring program, which is not in Texas, but they promptly leave town to visit friends out of state. They never get a hold of whoever's supposed to monitor them, and they are quickly lost to follow-up due to multi-state travel. And then they go to a rural retreat to report on what happened in their mission, and other people got what everybody thinks is the flu. They assume that they have the flu as well, but one of them starts getting worse and worse. And so she goes to the closest urgent care center, gets a flu test, and since now she is throwing up and having iffy blood pressure and looking pretty sick, they say, let's send her to our friendly small local hospital. So wherever you are, think of your friendly small local hospital that this person might be sent to. What are you going to do? So this is not the ideal setting at all. Is this hospital ready? Will they recognize she's a potential Ebola patient? Will they institute appropriate protections for healthcare workers? Do they know who to call? And will they be able to provide care? So the basics, be prepared and have a plan. This is why you think about, okay, what would happen in my facility if this happened? So do people at your facility know to think about this stuff? Do they know are there signs up telling people if they've been traveling anywhere and they have certain symptoms to identify themselves? Is there symptom and travel screening going on with a plan to respond if there's something worrisome? Does everybody know that if something is worrisome, you promptly move somebody to a private room, limit the people that go in there, and get people into appropriate PPE, and tell the patient what's going on and tell the appropriate public health officials. So what PPE? All right. You know what the real answer is? We know none is bad. We know that too much can also be bad, and somewhere in the middle of there is the right amount. So we tend to talk about it as sort of dry patient, that's pretty much COVID PPE, and wet patient, where you add some extra layers. Basically, you get yourself completely covered up. Do we know that you need that for Ebola? No. Do we know exactly how most healthcare workers who have become infected got infected? No, we don't. So it's important to recognize the different PPE options that are advocated by different organizations. There's not a lot of science behind it. So on the right is what I wore while I was providing care. If you look, there's skin exposed. On the left is what a lot of the organizations such as MSF were using. People jury-rigged and did strange things that I didn't approve of. And now most of us have have a plan to use fairly complicated bits of PPE in our own environments and use a PAPR. But the main point to be said is that's not necessarily required, but you do need to know what you've got. So remember, you've seen this before, those administrative controls. PPE is down here as one of the least effective things you can do in terms of if you don't have other types of controls, the PPE is not going to protect the worker. So for example, I mentioned limit people exposed. If you've got somebody who might have a highly infectious disease, have only a few well-trained people going in and out of that room. Ideally, you've got a room or a space layout that allows people to safely go in and safely go out and don and doff their PPE safely. And ideally, you've got at least a few people who are trained in order to train others if necessary, and you schedule their availability so that nobody gets exhausted, nobody's overscheduled, etc. You do that, and the PPE becomes one of your barriers, but not your only. So the two things that I'm going to say here, so everybody should at least be aware of what the principles of the PPE are, but the most important thing is more isn't always better, because most experts think it's taking it off that's the most dangerous time. And if you figured out everything that you want to put on, but you haven't figured out how to take it off, then you're going to run into trouble at that time. So infection control people can help by having sort of standardized risk packets, by going over how it goes on, how it goes off. And even if the rest of the staff are not trained, that there's somebody that can come and explain with the PPE that we've got, what do you do with it? All right, here's a trick from the field. What if the stuff you get sent changes and it's not exactly the same type of PPE? It still fulfills the criteria, but maybe the order in which you have to put it on is different. That means the order you take it off is going to be different. So somebody should go through all that before just handing out different PPE and say, here, put it on differently. What about in the lab? Okay, here's an infection control issue. So, okay, you've maybe learned and talked about, and if you've paid attention to some of the information coming out from the state lab and so on about what you would have to do to test someone for Ebola. But you've got a sick person and the clinician is saying, but we need a CBC and I can't send that to the state lab. I just want to send it to our lab. Well, now what? What are the infection control considerations to doing testing in a lab? And that is something that really, really hampers a lot of response. And to be honest, there's not super easy answers to that. CDC has some information that helps to discuss what can be safely done, but it's not super clear. But this is another one of those risk assessment things. This is the kind of thing where you do want to go in the lab, figure out, okay, if we had somebody who might have Ebola, is there a way we can do a CBC? How would we do it most safely in the lab? Look at what can be done to mitigate it. Maybe have a couple of people trained, maybe have a specific area assigned where that kind of specimens would be handled, and so on. Use as many point of care tests as possible that can be done, hopefully, by the healthcare provider in the room with the patient. And then medical waste has been discussed. When you're dealing with medical waste that is with a high consequence pathogen, two things. There's a lot of it. All that PPE is considered high consequence medical waste until you know better. Now, if you're ruling somebody out as to whether or not they have something like Ebola, you're going to need to sequester all that waste until you know yes or no, and that might be a couple of days. So you need to think about where are you going to put that waste? How are you going to sequester it? And be making plans for getting rid of it if it does turn out to be the real thing. If it's not the real thing, you can get rid of it just like everybody else, just like everything else. There's a lot of Department of Transportation guidance that's available on that as well. All right, in terms of NETECs and biocontainment units and people, RESPECs and those of us who actually work in that field, when do you call us? In terms of transfers, all that goes through your local health departments and state health department and so on, but it requires time and planning. It's not just call up the hospital and say, hey, we're sending you somebody. But informal communications should begin much earlier. So both clinicians and IPC professionals, we are always available for discussion of possible cases to help out. If we can't help, we can find someone who can. So know that that's who we are. There's going to be recordings of this, so this is how you can connect with Spectre and reach out to us if you wish to do that. And now I have to give it up for announcements.
Thank you, Dr. McLellan. And just before we go, we just want to do a couple announcements. After those who have attended today's module, there'll be an email sent out as a post-module survey. We would love it if you could complete it, give us feedback on the material, how today's presentation went. The next module, titled Environmental of Care, EOC, will be presented on July 19th from 2 to 3 p.m. Central Time. It will be a virtual. We will be sending out registration just like we did with this one. The main components of the next module is that we are going to explain construction and renovation practices, identify safe environmental hazard practices, and describe environmental disinfection practices. Thank you all for attending today and for your attention to TEPHI and Spectre's joint infection control series. Feel free to hang back and network with us, and we will open it up now for some question and answers. And then here's our connection. Dr. McLellan is still here too, if you guys want to open up and ask us some questions. And then, yes, the slide deck will be posted on the TEPHI channel. You guys will be able to download it. And then here's all of our links, all the forms that we presented as well. The links will be in reference to. So feel free to post questions in the chat, and we will just scroll through and answer them, or unmute yourself as well.
In chat. So we're doing it in chat, not in Q&A, right?
Yes.
Biocontainment rooms.
Our biocontainment unit. So isn't that an interesting question? And remember, there's 13 of us. And so that's actually a discussion that we sort of have. There are a lot of things that potentially influence that. So for example, and some of them are just administrative hassles and the way it's set up in one unit versus another. So for example, first COVID patient, first highly suspicious COVID patient in Texas was sitting in Houston, and nobody would take him. And eventually we took him. But we ended up placing that person not actually in the BCU, but in a ICU room with negative pressure, which all of our BCU rooms have as well, and staffed it with our BCU team. But it had more to do with what was thought of as inherent cost of opening the unit, okay, than it did to do with anything else. Now, since then, we have used it for exposures for early COVID evaluation. We sort of shifted over to that. But fortunately, we have not had a full-on, fully sick Ebola patient here in our biocontainment unit in Texas. Are there, a PUI in Texas, as is true, in fact, of the entire HHS Region 6, is expected to get their preliminary care at the hospital where they land. Okay, we don't take people to rule them out unless it's a highly, highly, highly likely exposure, and that decision would be made with the state of Texas and with CDC. Okay, so so we don't open up for every person who came back from an Ebola country and who now has a fever. It's a long answer to a short question.
Anything else?
Any other questions from our online or virtual presence? No? Well, feel free to reach out to us. The slide decks will be available both for the Spectre team and the TEPHI team, and we will conclude today's infection prevention joint Spectra module. And thank you all for participating.